So I want to officially start this webinar. My name is Eileen Michelli. I'm with the Marfan Foundation. Welcome to our final webinar in our special surgery series, which is part of our educational efforts for Marfan Awareness Month. We're thrilled to bring to you outstanding medical information from leading surgeons from around the country, who are also huge champions for the Marfan Foundation and, of course, for our community. Tonight, we're featuring the fabulous Dr. Anthony Caffarelli from Hoag Hospital in Orange County, California. And if you're suffering from the cold this winter, start planning for our 2022 annual conference, which will be hosted by Hoag in Newport Beach, and promise you it's gonna be warm, beautiful, and amazing. Before we get to our speaker and the official introduction of him, first I'd like to ask our President and CEO, Michael Weimer, to say a few words.
Thanks, Eileen. Good evening. I just wanted to come by and say hello and check in with Dr. Caffarelli on how things are going. And you're in for a real treat this evening. You've heard of the 4 great tenors. Well, we've had the 4 great surgeons. And this is Eileen noted as the wind down of that series. And, you know, we're also coming up on the end of Marfan Awareness Month. And thanks to everyone for your support of the foundation and all that we do. We will be in person next year at Hoag, which will be very exciting. After 2 years, we were unable to hold an in-person conference. But, and I think we'll have a slide later on, this coming July, we will have a virtual annual conference. And it's going to be focused about 75% on connecting and probably 25% on the more traditional medical and other kinds of programming. So people have really been looking for an opportunity to connect, and our conference is hopefully going to provide a wonderful opportunity to do that. So Tony, thank you for everything you do. You're amazing. And it's an honor to be here tonight in your company. Eileen, back to you.
Great, thank you. Thanks, Michael. So as you know, tonight we are talking about aortic arc surgery. We do have an opportunity for you to ask your questions. Many of you submitted questions in advance. So what I recommend is wait till the end of the presentation, because I'm sure Dr. Caffarelli is going to be answering a lot of what you're going to be asking, and then just put your questions in the Q&A box. The chat is just for chatting, but we're going to look at the Q&A box later for the questions. And we'll leave time at the end. We'll leave plenty of time for that at the end. So our speaker tonight is Dr. Anthony Caffarelli, the Director of Cardiothoracic Surgery at Hoag, as well as Director of the Elaine and Robert Matranga Aortic Center and the Newkirk Family Endowed Chair in Aortic Care at Hoag. He performs hundreds of cardiac and thoracic procedures annually, specializing in complex aortic procedures, including aneurysms, dissections, bicuspid aortic valve disease, and valve-sparing root procedures. For us at the Marfan Foundation, as you've heard, Dr. Caffarelli is a true champion. On top of his outstanding clinical care, he's always there for our community. Together with Dr. David Liang, our professional advisory board member, who now splits his time between Stanford and Hoag, they have built a premier aortic center and provide comprehensive care for people with Marfan, Loeys Dietz, and beds, as well as other aortic conditions. I also need to shout out his team, including Rita, who did the set decoration as we heard tonight, and of course his clinic coordinator, Meg Boglin, who is an amazing advocate for our community, and she also has firsthand experience as somebody who has beds. Dr. Caffarelli and Hoag are huge supporters of our Southern California Walk for Victory. And I'm not sure that orange mustache is going to make an appearance tonight, but it's always a lot of fun down in Newport Beach. And as you've heard many times already tonight, Hoag is going to be sponsoring and hosting our 2022 in-person conference in Newport Beach next summer. So with that, I will get rid of my audio and video and pass the remote over to Dr. Caffarelli.
Thanks, Eileen. Thanks, Michael. Let me, so Eileen, as far as sharing my screen, there we go. And
so you have that?
Allow Zoom to share your screen, open system preference. Oh.
Yeah, let me try again here. Let me just get this. Let me do this. And then I can let me see, remote control, Anthony Caffarelli. Okay. How Have it now.
Share screen.
And then you pick your screen.
Yeah. Sorry about this.
It's
Says
okay.
system preference.
This is live TV.
Yeah, exactly. Allow the Asplet to record the contents. Yes. We may have to call a friend. Hey, Rita.
Here
You
she
do it,
comes.
Meg? Meg's coming in to save the day. Allow Zoom. It's not letting it happen.
You did that?
Yeah, I did that. And then that pulls up. I hit desktop. But it says,
Is it up on your screen?
yeah, it says allow Zoom to share your screen, which I've done many times before.
So click on the presentation, it will highlight and then go back and at the bottom and press share.
Yeah, nope, I understand.
Hey, Eileen, on my
Mhm.
screen, it's showing that I can share screen. So should I be able to, should I be off that?
Yeah, just, yeah, if it says where it says remote control, make sure it says, yeah, I mean, I picked giving it to him, so all panelists, who gets, oh, all panelists, try again. Have it now.
I'll try it one more time.
Okay.
I think it's on my end. Security.
Why
policy,
don't you, I'm going to,
security.
I'm gonna send you a, sorry, everybody, I'm going to send you guys a, Tony, I'm gonna send you an email address. If you wanna send me your slides, I'll pull it right up. You can send that, they just sent you that email address. You can send me the PowerPoint, I'll get it right up here.
I think I got to leave the meeting and log back on. It's telling me.
Okay. All right. Okay, so hi, everybody. We'll see, let's see what's going on in the chat.
I'm going to say hi too. Well, welcome. We've got Australia in the house. We've got Canada in the house. We've got Colorado in the house.
Maybe what I could do is talk, while he's doing that, maybe I can show a couple of things that we were going to talk about later.
Sure.
So, yeah. So while
I
we're
get-
waiting.
I see Gary. Sorry, Eileen.
Okay, while we're waiting, let me just remind everybody that if your questions are not answered tonight, the best thing to do is to send them to Jan Lynch, who's our amazing nurse. There's her smiling face there. And the best way to do that is through our website, marfan.org/ask. And then she will be able to answer those questions. This is way better than calling her or emailing her. So you can use
Eileen, by the way, there's a question from, I think it's Jess Winder from London.
Oh,
We will continue to have virtual sessions.
Great. Yes.
This is the end of the surgery session. We have a lot of additional sessions that will be coming up. So,
Oh, look what we have here.
We're back.
Okay, so I'm going to stop my video and my audio. And so Michael and Helene, same.
great. Hi, Heidi. I see Heidi's in from California. I'm off.
Okay, goodbye. Okay, you just need to make that like a slide view so we can just see just that one slide. Can you?
Yeah.
Great.
Okay. So you can see it now?
Perfect. Perfect.
Good. Okay, perfect. You guys, sorry for about the technical difficulties, but computers are not our forte. So once again, I want to thank everyone for having me. I'm really looking forward to tonight as essentially an educational forum for patients and family members out there. Eileen, Helene, Michael, thank you for the invitation. Just as a quick outline, we'll go over a little introduction. We'll go over some anatomy, some history. We'll look at indications for surgery. We'll go over some concepts that we use in the operating room. I'm not going to show any OR pictures because they were around dinner time. And then we'll do some patient-specific information. We'll keep it short. But why is aortic arch surgery different? Well, the Marfan Foundation and the rest felt it was different enough to have its own talk. I believe that to be true. Arch surgery really gets me going because it's complex and there's a lot that you're juggling. But in order to understand why it's different, we need to understand what normal is. So on the left, and you guys are probably the most, the smartest, educated patients that we see in our clinic. And for that, I love it. So if I'm talking below anyone, I apologize, but for those, this is supposed to be educational. On the left, we see a picture of the entire aorta broken up into different zones. We have these zones now, thank you to our STS database. And that's really so that we can capture data, talk about apples to apples and oranges to oranges when we talk about different procedures or pathology that we're treating. As you see here, this is the root that Dr. Roselli spoke about, the ascending aorta. We're going to spend the majority of today's talk on the arch, and then the descending aorta or thoracoabdominal aorta, as Dr. Caffarelli spoke about. But since we're going to focus on the arch today, let's look at that in detail. Why is the arch important? Well, this is where all the blood flow up to the brain is there. So here you've got the innominate artery, which spreads into the right carotid and then separates into the right subclavian. You've got the vertebral, which handles really the circulation to the back of the brain. And then separately is the left carotid and then the left subclavian. Off the subclavian comes the vertebral. So parallel systems, symmetric, but that can be varied. And obviously with connective tissue disorder patients, Dr. Roselli showed slides like this, so I'm going to go over this pretty quickly. With normal aortic wall, it's very organized and therefore structurally it's intact. When you have a genetic disposition to a connective tissue disorder, then things are very disarrayed. And unfortunately, this leads to loss of structural support in the aorta, which causes the catastrophes that can occur. Our job is to prevent these from happening beforehand. The aorta, it's the largest blood vessel in your body. To me, I always tell people it's the largest freeway that we know of. Its job is to deliver blood from the heart all the way up to the top of your head and then the bottom of your feet. The way it gets there is different branches. And so first set of branches, you've got the coronary arteries that feed the heart muscle itself. Then the large three branches that go up to the brain that are so critical with arch surgery. And then you've got branches that go off to the spinal cord. You've got the 5 major branches down in the abdomen. And then at the belly button, it splits right leg and left leg. Well, the aorta, it's its own living creature because as the heart beats, it pushes that jet of blood and then the aorta distends during systole. So it expands, and under that maximum expansion, the pressure in there is the top number in your blood pressure. And as the aorta recoils due to the muscular wall, it's pushing blood to the next segment. That's the lower number in your blood pressure. So what I teach my patients is it's kind of like that game we played as kids. It's that egg toss game. You toss the egg. If you didn't break it, you take a step back and you keep going until the last team standing. Well, who's the last team standing? How did they achieve that? Well, number one, they could toss. Number two, they absorbed the impact so that egg didn't break. Well, that's the aorta's job. Because of the muscular wall, it absorbs the impact from the heart. And as the aorta gets larger, less ability to absorb the impact, that's where there's shear tension in the walls, and that's where rupture or dissection can occur. Our job is to prevent that. Obviously, to understand why arch surgery is different, we got to understand what normal is. Here's a schematic of a heart, potentially in the operating room, where we have a cannula in the vein. In that vein, we're going to capture all the blood that's coming into the heart. That blood is going to be taken away. It's going to go to the heart-lung machine. And then from the heart-lung machine, it's going to be brought back in through a tube or a cannula in the arch. Well, this is going to really allow 3 major components to occur. One, the heart-lung machine pumps the blood. So that takes over for the heart. and then it's going to put oxygen in, carbon dioxide out. So therefore it takes over for the lungs. That's why they call it heart-lung machine. The other major thing that it does with a separate device is it can cool and warm the blood. This is critical for organ protection, specifically in arch surgery. But if we go back, if we're talking about doing surgery on the arch up here, our normal cannulation strategy isn't going to work because this is the area that we're going to be operating on in arch surgery. So why is arch surgery different? Well, it's really a balance. As the surgeon, you're balancing the heart and protection of the heart, along with providing adequate blood flow to the brain, and then providing good blood flow to the rest of the body. And the conduct of the operation is critical to achieve all three perfusion beds. So of course, we have to talk about history. And the first arch aneurysm resection was actually in 1950 in Paris. It was a 20-year-old girl who came in. They thought she had tuberculosis because she had a mass that was protruding on her chest. They stuck a needle in it and it actually had blood. So the surgeon said, well, we'll take her to the operating room and see what we can do. And they resected that aneurysm. They didn't use a heart-lung machine. They really just put clamps on the bottom, resected it, and then oversewed it. In the operative note, it says they were actually surprised that she made it. Well, obviously a lot has happened since 1950, and Dr. DeBakey down in Texas actually did the first ascending and arch replacement. He did that with 2 homografts, so cadaveric aortic tissue, and he actually used separate cerebral perfusion. Cerebral meaning brain, so he actually perfused the brain all the way back in 1957. Kind of the next major advance was in 1968 with Dr. Bloodwell, where he not only perfused the different brain segments, but he actually reimplanted all 3 of those arch vessels as an island. And I'll show pictures of that later. But really the biggest contribution was in 1975 with Dr. Greep, where circulatory arrest was really advanced. It had been done before, obviously, but Dr. Greep really advanced that. And I'm going to show you a slide later on where we talk about that. And then in 1983, Dr. Borst fashioned the elephant trunk procedure, and we'll go through pictures of that. These are kind of some of the major advances in arch surgery. Obviously, you can't just have normal. Normal is normally a 3-vessel branching pattern. Bovine arch, which is commonly seen in our bicuspid patients. This is where the left carotid and innominate form off of a common trunk. You can have an isolated vertebral. So instead of the vertebral coming off the subclavian, it can actually come from the arch. So if you're doing an arch replacement, you need to know that this isn't coming off of the normal location. And obviously a more extreme version is where the right subclavian is aberrant. Instead of it coming off of the innominate up here, it's coming directly from the arch and then will run around either the esophagus. Sometimes it'll run in between the esophagus and trachea. And those can obviously cause problems with swallowing and breathing. Since this is a very well-informed community, we also classify arches on the type of arch, a zone 1, a type 1 arch, a type 2 arch, or type 3. And that's really in relation to the location of the innominate. If the innominate's in a horizontal plane with the other 2 vessels, it's a type 1. If it's within this range, it's a type 2. If it's a very what we call cervical arch, more of a steeple, then we classify it as a type 3 arch. So why would a person need an aortic arch surgery? This is actually a picture of one of our Marfan's patients who had a previous root procedure, and she has a very large abnormal arch aneurysm. So let's go through some of that. I think for this talk, the easiest way for, I think, patients to understand this is we need to look at acute conditions, and then we need to look at chronic conditions. So acute conditions, obviously, we're looking at acute aortic syndrome. Aortic dissection being the most common that we can treat. Obviously, there's intramural hematoma and then penetrating aortic ulcers. But with our connective tissue disorder patients, it's the dreaded aortic dissection that we're treating. For the chronic case, this is where you have an aneurysmal arch. And that aneurysm could be because there's residual dissection left over from the first operation, and because of blood pressure and weakened aorta, that now dilates over time. That's why imaging is so critical to follow this. So we have certain criteria. Typically, just as a generalization, 55 millimeters is what we utilize, but that obviously has to be taken into account the patient's body size. Also, rapid growth, if we're usually seeing growth more than about 2 millimeters per year, or if there's a saccular aneurysm forming. Not that common in our connective tissue patients, but if, let's say, a cannulation site had an issue there, that could be one indication. So with that, we can really focus on some of the acute issues. So obviously aortic dissection with classifications, there's the DeBakey classification and the Stanford. Having been from Stanford, I'll obviously use that, but with the Stanford A, that's where the ascending aorta is involved. If the ascending aorta is not involved, we classify it as a type B aortic dissection. With the DeBakey classification, a DeBakey 1 is obviously the ascending and then extending all the way down. DeBakey 2 is limited to the ascending, and DeBakey 3 is similar to a Stanford B. With the primary goal of a type A aortic dissection surgery, it's really to prevent death from aortic rupture. And that's because the ascending aorta is contained within the pericardium. As that tear starts to weep fluid, that pericardium can fill with blood, pushing pressure on the heart and limit its ability to function. So the first objective, replace that bad ascending aorta. We also have to excise the primary intimal tear. So primary intimal tear, 60% of the time can occur in the ascending aorta. Other times it can occur up in the arch and then go backwards. So to identifying this is crucial. And then we want to restore a competent aortic valve and then restore dominant true lumen flow distally. Because as flow goes into the false lumen, obviously you have only 1.5 layers trying to hold that pressure together. So I'm including this with arch surgery because if your primary intimal tear is involved up in the arch, then you have to do an arch usually for that patient at the time of surgery. Also, if the cerebral vessels were compromised, restoring flow is crucial. So sometimes at the initial operation of aortic dissection, you're doing an arch. Just this week, a patient came in with stroke symptoms. He was aphasic. He was moving everything, but not to command. He was found down at home. We took him to the operating room, replaced his ascending, and then his nominate was reimplanted and his left carotid was reimplanted. So his zone 2 arch, fortunately, the guy woke up and he's doing very well. So these are things that surgeons have to be aware of and able to complete to take care of patients. So I'd say for conventional type A repair, when we look at the data from the STS, most surgeons are really doing a supracoronary anastomosis and then what we call a open distal in the distal ascending aorta, or a hemiarch procedure where you're going underneath the arch. When you're doing this under open conditions, you need to use what we call circulatory arrest. That we'll discuss later. Obviously, this is not the operation we would recommend for any patient with connective tissue disorder, and especially the Marfan's patients. With the Marfan's patients, what we've realized that the aortic root should be addressed. And when it's not addressed, Dr. Bavaria has got a great paper out there that showed 40% of patients had to come back for re-intervention on their aortic root. And so when that root is performed at the time of surgery, Dr. Roselli did a great talk a couple weeks ago, and your options at the time of emergency surgery, you can have a composite valve graft with either a mechanical valve, a composite valve graft that you can build with tissue valve, or now there's another product out there that's already built in, or a valve sparing aortic root procedure. Still done in the emergency setting, but more commonly done in the elective setting. So one of the questions that kind of comes around in our surgical community is, should surgeons address the aortic arch at the time of the first operation or the index operation? We're going to go through 3 studies. I promise you, we're not going to go in detail. It's not my style. but I think it is important because it helps guide what we do as surgeons. The first is from Dr. Carrel and his French colleagues, where they investigated whether total arch replacement during initial surgery should be performed routinely. And now this is for a prophylactic root aneurysm, so not emergencies. And so they did a retrospective analysis. They looked at 94 patients who had 148 aortic surgeries in a 16-year period. So that means 94 patients, some of them were getting more than one or sometimes two operations. So for primary total arch, how many times was this done in an elective route? Only 1.6% of the time. But when the patient presented with an aortic dissection, 8% of the patients got a total arch. When patients came back for secondary procedures and they got a total arch, the mean time was usually about 8 years, give or take 6. And then of that, how many had elective routes? 3%. And then, but how many had initially aortic dissection as their presentation? 33% of patients. So the dissection patients came back for total arches later, where only 3% of elective root surgeries came back. So the conclusion from this study, when you're a Marfan's patient and you're undergoing an elective root repair, there's no need to do a total arch at that time. Now, once again, these are guidelines, and for all the listeners out there, each patient's a little bit different. So I don't want this, you to, be mad at your surgeon if they did a total arch. These are unique situations and they have to be personalized. But if the patient had an aortic dissection, the need for reintervention was precipitated by the dissection itself, not the first operation. So it kind of reiterates what we know, that dissection is bad and that residual dissection downstream, especially if the false lumen does not thrombose, can lead to problems such as dilation. The second study, this was Dr. Bichet and his colleagues in France. So the purpose was to assess the prevalence, indications, and results of aortic arch replacement in Marfan's patients with and without dissection. And so they looked at a 12-year time frame where they had 54 patients that had 76 operations. The average age was 38 years old. And so, but when they performed 76, but when they look at the patients, because some patients transferred into their aortic center or came as second opinions, 54 patients had over 100 operations. So some patients are getting obviously first and then second surgeries, some even third and fourth surgeries. So performing the right surgery the first time is crucial. So indication for their initial surgery was elective root. And then how many had acute type A's? 35%. 4% had type B's, 15 had chronic B's. Now, what was the indication for the re-op? Well, residual chronic dissection in the proximal aorta, 36%. So that means in the Marfan's patients, do you guys see my screen?
Yeah, you're good.
I just lost it for some reason. Okay, I've got it. So 36% had residual proximal aorta. So even though they're Marfan's patients, the surgeons didn't address their root. So of course they came back. And this is similar to what Dr. Bavaria showed in his study, about 40% of patients. And then indication for re-op was the distal aorta. So 56% of patients, because they had false lumen expansion, or some people had acute retrograde type A's. So starting elsewhere in the arch and then came backwards 8% of the time. So once again, confirming that prophylactic replacement of the arch is not indicated when you're going in for elective root surgery. But if it appears logical in patients presenting with acute type A to consider doing the total arch to reduce the number of reoperative procedures in these generally young patients who are already paying a high toll for their disease. But that's a hard recommendation to do, especially when you look at our data. So in the STS database back in 2017, Most operations in the United States were performed at centers where they do less than 3 aortic procedures a year. So to ask those centers to do total arches is I would not want my surgery done there. So we got to take these with a little bit of a grain of salt. In May of this year, Dr. Cameron and his colleagues presented a very interesting study, and this compared the Loeys-Dietz patients with Marfan's patients. This is a busy slide, but we're going to walk through it. So they took 79 Loeys-Dietz patients, and they essentially separated them, those with dissection versus those without. So 11% initially presented with a dissection, 8 to 9% that didn't, but then in follow-up, some crossed over because they had dissection in their follow-up period. And the same is true for the Marfan's patients, those without, those with dissection. And so at the end of the analysis, they had 12 Loeys-Dietz with dissection, 67 without, 26 with dissection, 230 Marfan's without dissection. And then in the absence of dissection, Loeys-Dietz patients had a higher rate of arch intervention. And that we can see down here. So here's the Loeys-Dietz patients with dissection. And they were similar to the Marfan's patients with dissection. But where the curves really separated was up here. And that is Loeys-Dietz patients that came in and had surgery on their root. They needed secondary interventions on their arches. But Marfan's patients that came in for their root did not need interventions on their arches. So their conclusion is, in acute type A dissection, arch interventions were really similar between Loeys-Dietz and Marfan's patients. But when you look at elective root repair, the Loeys-Dietz patients had an increased risk for subsequent arch interventions. So therefore, consideration of addressing the arch in Loeys-Dietz patients for elective root repair should be considered. Now, once again, this is a challenge too, because a lot of the grafts we have are really made for adults, the sizes of them. And the Loeys-Dietz patients usually present sooner than the Marfan's patients. So Dr. Cameron's got a very nice discussion in his paper that talks about this. So that's it for the scientific component of it as far as studies. The rest, we're all going to do clinical applicability. So once again, should surgeons address the aortic arch at the first operation? I'm going to show you a picture that I hate showing, but my team loves showing it, so I threw it in for them. And that is, it really depends on the indication of the first operation. So if you're there for elective root surgery, Marfan's probably not going to get a total arch, but Loeys-Dietz patients for elective root should be considered because they have a higher risk for arch intervention. So in aortic dissection, obviously the similar arch issues for Loeys-Dietz and Marfan's. So it's going to be patient specific because you always have to worry about the fate of the distal aorta. Okay, so with that, let's talk a little bit about aortic arch surgery specifically. So there's several different types of arch procedures. I just wanted to make it simpler for everyone so that you could retain this information. And we're going to look at 3 kind of common procedures. The first is the hemiarch. The hemiarch is really where you're doing a partial arch. And this is what we call a peninsula style technique, where you essentially have a peninsula of Dacron going underneath the arch. The purpose here is to try and eliminate as much arch tissue without doing a total arch. And in the acute setting, such as an aortic dissection, this is found to do very well for connective tissue disorder patients as well as non-connective tissue disorder patients. And by far is the most commonest procedure that we do. Next is the island reimplant. Why is it called an island? Well, we're taking an island of the head vessels and reimplanting it into the graft and then suturing it into the proximal descending thoracic aorta. Okay, this is not what we recommend or would do for most patients with connective tissue disorder, especially Marfan's or Loeys-Dietz, because we're leaving aortic tissue behind. So the most commonest procedure is where we do a total reimplantation. Total reimplantation means we're going to get rid of all the aortic tissue and we're going to do individual reimplantations. Now, this picture is a representation of what we call a 4-branch arch technique, 4 being the 3 to the head vessels, and then the 4th is a perfusion graft, so we can provide blood flow from the heart-lung machine. There's a variety of configurations that surgeons have done to reconstruct these vessels. And there's a variety of commercially available grafts that allow us to make these connections. One is there's trifurcated grafts where you connect the head vessels together and then you reimplant it into the arch in one location. So not to bore you with the technical aspects of it, we have lots of tools in our tool belt. The elephant trunk procedure. This is important for our connective tissue disorder patients, especially Marfans and Loeys-Dietz, where they have risk for intervention on the remaining segments of their aorta. And if you do a root total arch, the descending's at risk. And so if you leave an elephant trunk behind, you're setting yourself up for success. So let's walk through and see what that really means. So we're taking a Dacron graft. We're going to intussuscept it upon itself. So fold it in, kind of like what you do for your socks. Put it in, and then once it's in, while we have the patient under circulatory arrest, we can drop that into the descending thoracic aorta like an elephant trunk hanging down. We can then unfurl the remaining graft and then reconnect the arch. Obviously, with our connective tissue disorder patients, we're going to do, the branch graft so that we get rid of all that bad aorta. But the purpose of this is we're leaving graft down here in the descending thoracic aorta. So in this representation, this patient has an aneurysm of the descending thoracic aorta. It's not big enough to get intervened on now, but it may be in the future if it grows. So we're making it safer for the patient, saving it for the surgeon, and making it a shorter operative time by leaving this down there. Because now when we come in through the side for a thoraco, we'll be able to put a cross clamp down here rather than up in the arch and, putting nerves at risk or blood vessels or anastomosis at risk. So it's essentially a preparatory step for a stage procedure. The Sun procedure. So this is, one thing that's talked about in the aortic community. And I got to say, it's a common procedure that a lot of us do for aortic dissections. How that's different, we've got a 4-branch graft, but this is actually a stent graft. And instead of a elephant trunk, this is termed a frozen elephant trunk because it's a stent graft that expands with springs with cloth inside. Now, once again, the Professional Advisory Board, the expert consensus document, and the AHA all agree that stent grafts are contraindicated in patients with Marfan syndrome and the related connective tissue disorders. The thought is with this that, all right, it may work because you pick the size, but if this now expands, you're going to have problems. And so obviously this is not a mandate. Stent grafts have been used in connective tissue disorder patients. Not as a first resort. It's usually a secondary resort when the patient's too sick, and we're going to use stent grafts to bridge to a more definitive operation. Or where stent grafts have been utilized is stent grafts require landing zones. So the proximal landing zone and the distal landing zone, and there may be an aneurysm in between. Well, if that proximal and distal are Dacron graft from previous surgeries, that could be one indication. But the talk's not on stent grafts, so we're going to put that subject to rest. Maybe we can address it in the Q&A. Here's a picture and some video of a 19-year-old Marfan's patient who came in a while ago. He had a root aneurysm that hadn't been operated, and you can see his initial presentation was a type B aortic dissection. So you can see the true lumen here, the false lumen here. Well, he went and got his root replacement done. He moved away. Got his root replacement done elsewhere. And then we met him again 5 years ago. And now he represented with a second type B dissection in the setting of a previous B. And this one now went retrograde up into the arch. And if you look on the left screen here, here's his true lumen, here was his false lumen, and the true lumen split again. This is an ominous sign in Marfan's patients, but we've got big problems. So now his arch is big and his descending is big. Down in here was about 8 centimeters. He was your typical 22-year-old kid. He didn't want to really face some of his medical issues. He was, going through some tough spots in life, and now he had a tougher one. So we did a stage procedure. So the first operation, we addressed his arch. So we did a total arch and then left an elephant trunk down in here. So we brought him back to fight another day, and then the thoraco was done. So here's a completion. Unfortunately, the video broke on the other one, so I had to get rid of the first, but here's now his aorta is completely replaced from the root, his total arch. Here's the elephant trunk that was left in place. And now here his completion thoracoabdominal with the intercostals in place. So these stage procedures are critical. And so setting yourself up for success for this next operation is crucial. So back to the original question, why is arch surgery different? Well, we're balancing perfusion to the heart, as well as blood flow to the brain, and then blood flow to the rest of the body. So how can we achieve this safely? Well, hypothermic circulatory arrest is a standard. Michael, I threw this picture in there for you. So this is a picture that was talked about notoriously at Stanford by Dr. Miller. And this is Dr. Greep's orange canoe. And it lived between OR 13 and 10. Back in 1975, patients were cooled down. The patient would be put in the canoe, ice would be put around the patient, and then the surgeons would conduct the operation while the patient was in the canoe. To warm the patient, the canoe would be deflated and the ice would be removed. Why? The colder you go, the better the organs are protected. And we know this from transplantation. Obviously, you can harvest organs, you can put them in ice, store them for certain periods of time based on their ischemic time, and then reimplant them. Well, without taking it out of the body, we can cool the body down, protect the brain, protect the heart, and then protect all the other vital organs, the spinal cord, the liver, the kidneys, the bowel. And with this, we have some nomenclature. This nomenclature has really been thrown around, and it's been hard to have a consensus, but we actually have consensus now. Profound hypothermia, we consider less than 14 degrees Celsius. Deep hypothermia, 14 to 20 degrees. Moderate hypothermia, 20 to 28. And mild hypothermia, 28 to 34 degrees. And by the way, this is Dr. Miller in 1975, which he thinks this is with an anesthesia resident. So the consensus on hypothermia and arch surgery, bottom line on this, the colder you go, the more protection that you have of the brain, and the more you're shutting down the metabolism. We all hear about the little kids that fall into lakes in Minnesota and frozen, you thaw them out, and the next day they go to school. Same concept, cold is protective. And with that, it allows us to perform operations, and the colder you are, the longer the organs are protected. But hypothermia is not the end all and be all. You need adjuncts, and adjunct is perfusion to the brain. And this is a concept that has been around, and this is kind of like religion in some centers, aortic centers. Some people believe in antegrade, some people believe in retrograde. So to help educate you guys, let's talk through that. Antegrade cerebral perfusion is where we're providing blood from the heart-lung machine in an antegrade fashion, meaning forward flow to the brain. So it's going into the artery, either through an axillary artery, which is common, or an innominate artery, so that it can go up to the right carotid, feed the brain through the circle of Willis, which is connections between the right and the left. It can then come down through the left. We're monitoring in the operating room. When we see differentials, we can always add another cannula up the left carotid directly. So instead of unilateral antegrade cerebral perfusion, we consider that now bilateral cerebral perfusion. With retrograde cerebral perfusion, retrograde backwards. So we're essentially providing blood through the vein, and you have to change your heart-lung circuit a little bit here, but providing blood back through the superior vena cava, so it goes back up through the jugular veins to the brain, and then through the veins, it's going to go venules, then capillaries, capillaries to arterioles, arterioles to arteries, arteries, now down to the carotids. But all the while perfusing the brain with cold blood. Essentially, we're creating a brain freeze. The whole point of that is to lower the cellular metabolism of the brain at the time. And for arch surgeons, this is mandatory. One of the ways we can do that, as we showed, is the right axillary perfusion. So this is where we're instilling flow, usually through a graft, from the heart-lung machine. This is a picture of an aortic dissection. So in the red is the true lumen, in the yellow is the false lumen. So where the false lumen preferentially pressurizes and can shut down the true lumen, we want to restore true lumen flow so we can get blood back up there. So this, to me, is what we would strive for. This would be an ideal scenario. We're pressurizing the true lumen, and the false lumen will now get smaller. But one of the things that you have to worry about, and it's mandatory when we do these surgeries, if you have a tear elsewhere and you institute flow and now it goes into the false lumen, you're actually going to be hurting the patient. Now the false lumen is pressurized, you're constricting true lumen flow, and that can minimize end organ perfusion. So in order to recognize that, there's a variety of monitoring systems we utilize in the operating room. So cerebral monitoring is crucial to achieve our task. And that is, there's a variety. There's bispectral index, which is looking at essentially the depth of anesthesia. There's EEG, where we're actually looking at the electrical activity of the brain. There's transcranial Doppler. There's near infrared spectroscopy, which is almost like a pulse ox for the brain. And then there's somatary evoked potentials, and then oxygen saturation. I got to say, there's, once again, these are really institution specific, but the majority of institutions are using bispectral index and near infrared spectroscopy, or NIRS. As in medicine, if there's something good, there's always some bad to it. So the colder you go, the bigger problems you have with bleeding, because the proteins that form coagulation or blood clot they're temperature dependent, because proteins are temperature dependent. And when you cool, those proteins are going to change. When you warm, you hope those proteins go back so they fit the puzzle pieces to form clot. But a lot of times when you go really cold, they don't do that. So therefore, hypothermia inhibits platelet function. Obviously, the longer the surgery, you tend to dilute your coagulation factors. And then when you're on the heart-lung machine, you've got a variety of problems that can occur. So therefore, in the operating room, we have point of care testing to assess before surgery, what does someone's coagulation profile look like? And then at that time, if it looks good, we can actually take blood off of the patient, just like donating at the blood bank, but we don't cool it and freeze it like the blood bank, because once again, that would interfere with the proteins. We keep it in the OR, we keep it on a rocker table so that we can instill it at the end of the case. So that's the patient's own whole blood that has all those coagulation factors. So that's the best transfusion you can get, because it's your own. I view blood transfusions as a liquid transplant. But having said that, a lot of times in arch surgery, we have to give you some. So using point of care testing, instead of hitting you with the blood bank kitchen sink, we're being very methodical about what we need to give the patients. Obviously, in the post-op setting, there's a variety of things that we're looking for. We obviously need a monitor for bleeding when we get up to the ICU. We need a monitor for tissue perfusion, whether that's direct measurements, like looking at the urine output or feeling the pulses, or indirect measurements, like checking laboratory values for the liver, the lactate levels, or the kidney function. We obviously want to do early extubation. A lot of times with circulatory arrest, I remember the patients would be asleep for 2 or 3 days after surgery, 15 years ago. Nowadays, it's very common for these patients to get woken up 1 to 2 hours after surgery and be extubated. Extubated meaning get the breathing tube out and get off the ventilator. Why is that important? Well, one, we start your recovery. And by starting your recovery, we're going to get a very good neuroassessment. Neuroassessment's critical. The risk of stroke in arch surgery is anywhere between 2 to 3% for elective surgery, but for emergency surgery, it can be anywhere up to 10 to 15%. So that's why brain protection is so critical. And that balance in arch surgery is what makes it very challenging, but fun at the same time. Obviously, early mobility, getting patients out of bed. A lot of times our patients after arch surgery, they're sitting in a chair about 6 hours afterwards. But also during the hospitalization, maintaining that mobility to prevent complications. Obviously, pulmonary issues are a priority, so working on the breathing machine and using your incentive spirometry and getting out of bed is critical. Specific with arch surgery, we need to monitor swallowing ability. Why is that? Well, it always goes back to anatomy. And with that, the left recurrent laryngeal nerve, which hopefully you guys can see this pointer, but off the vagus, the left recurrent laryngeal nerve wraps around the arch. And it usually does this between the left carotid and the subclavian. Well, if we're replacing that, that nerve can be at risk. Usually in the acute setting, we can, sometimes we can see it depending on how much aortic destruction has occurred. For chronic aneurysms, you can usually see it, but sometimes the inflammation can make it challenging. Why is the left recurrent laryngeal nerve important? Because it goes back up here to the larynx and it innervates the vocal cords. Here's a direct laryngoscopy of the vocal cords. The vocal cords normally sit midline, and then when you talk, the nerves pull the vocal cords apart. Well, if the nerve is injured, then that vocal cord is pulled off to the side. Well, the problem with that is now you have an direct opening to the lungs. Well, the saliva that we have in our mouth starts breaking down steak. If you swallow and that saliva misses the first barrier, which is the epiglottis, now the saliva is heading down towards the vocal cords. The vocal cord should be shut to protect the lungs. If you have a paralyzed vocal cord, the spit can go right down into the trachea and then start breaking down the lungs because it can't tell the difference between steak or lung tissue. Because of that, aspiration is a risk. So we want to assess the patient's vocal cord, which is a very easy bedside test to do. Postoperative imaging is critical. With that, we're going to be following echoes. We're going to be following CT scans. Some patients can be followed with MRIs. And obviously for patients that came in an acute setting with a dissection, we're going to want to do genetic testing to try and get to the etiology as to why that happened. So what does the future look like? Well, in the field of aortic surgery, we need to clean up our act a little bit. And there was a consensus statement that tried to do that. And that is, looking at standardizing clinical endpoints, making sure that we have meaningful definitions so that we can then obtain meaningful data from institutions. And I got to say, when Dr. Bavaria was head of the STS, he did a phenomenal job on improving the STS database and really beefed up the aortic component of that. With that, we're actually able to assess outcomes. And the most recent one looked at circulatory arrest in arch surgery. And it showed that most centers around the country were really just doing circulatory arrest. But when you do circulatory arrest without that adjunct cerebral perfusion, operative mortality was around 15% and stroke risk was around 12%. When you add the adjunct of cerebral protection, either antegrade or retrograde, you're actually decreasing operative mortality and decreasing strokes. So, and what's the objective for this? Well, obviously improve patient care. That's our end game. In order to achieve all this, you need an aortic center team. That's going to comprise a variety of individuals, the surgeons, so the cardiac surgeons, the vascular surgeons, the orthopedic surgeons for the orthopedic issues that the connective tissue disease patients have, obviously the cardiologists, the cardiac anesthesiologists that help in the OR, the radiologists that help with the imaging, the geneticists that help us to decipher some of these, rare mutations or variants of unknown significance. and then OBs, ophthalmology, your nursing team that's obviously, up on the floors in the ORs, your dedicated navigators and people that run the clinics, like with us, Rita, and also Meg, and then advanced imaging with our 3D lab, obviously your laboratory for pathology and testing, and then you need the IT support to square all this away. So with this, I got to brag about our team. In the upper left, we got some of the members of our clinic team. Rita's up in there, and then Meg Bogan's off over to the right. Up on the right is some of our OR staff. Bottom left is some of our ICU staff. And up on the here is one of our PAs, Jeff Saunders, and then our nursing staff on the telemetry unit. So with that, we're going to end and then start taking questions. But I want to thank the Marfan Foundation for having me this opportunity. I love teaching patients, but it all goes back to where I started from, and that is Dr. Miller trained me how to do this along with Dr. Mitchell. And then Dr. Lang taught me the medical aspect of this, and really the love of taking care of the Marfan's patients and the other connective tissue disorders. So with that, thank you very much. And I'm going to stop sharing my screen.
Great. Now it's just you and me. That was amazing. I learned an awful lot. There are things that we really haven't talked about before. So you were right. This was definitely needed to do something just on aortic arc surgery. Lots of questions. I see only a couple that were posed tonight, but right now we're going to go to the ones that were asked ahead of time. So you talked a lot about the need for aortic arc surgery after somebody presented with dissection, and less so if it was prophylactic surgery. But what are the indications for that aortic arch repair? You hear about with the root, you hear about the size of the size, or are there symptoms? So how do you know if you need, how do you know, or how does the patient know, or how does the surgeon know?
Sure. Yeah. There's not a lot of symptoms that occur with arch aneurysms. Obviously, if it's so big, you're going to get compression on adjacent structures. So sometimes people will have hoarseness because that left recurrent laryngeal nerve I talked about gets stretched out. As it gets stretched out, it's not going to work on that left vocal cord. And so people can, describe hoarseness. But I got to say, a lot of these are found on interval imaging studies that are done. And so after an aortic dissection, it's mandatory to do imaging. The guidelines say at discharge 1 month, 6 months, and then a year. And then based on, what you're seeing, that's where we see it. And as far as guidelines, as far as size, it's usually around 55 millimeters, but you have to take that with a grain of salt as to, how tall, the body surface area of the patient. And, with our Marfan's community, there's a lot of tall Marfans, obviously. We also have some short Marfan's patients too. So you can't use the absolute size. So this is where, that's why I love doing this stuff. It's personalized medicine. You got the guidelines, but you got to take it with that patient. So we're not just treating a CT scan or genetics. We got to put it in their body and see how does it fall out with the whole thing.
How long does that surgery take, the aortic arch surgery? Or so it doesn't matter which one of the ones that you showed us? It looks like it looks complicated.
Yeah, so I think if we had to walk through, if we're talking about a primary operation, the hemiarch procedure, I got to say, is relatively quick. The open portion to sew that, I always tell my OR team, we're sewing this many circles today. So to sew that one circle distally usually takes anywhere between 14 to 25 minutes, depending on who's helping and how bad the tissue is. When you're doing a total arch implantation, each circle, the smaller circles usually take about 5 to 8 minutes to do. But if it's an acute dissection and the tissue's really torn, you got to add a little bit more to it. If it's a redo surgery, the redos are always really driven by the amount of scar tissue left behind. The good thing about having a connective tissue disorder is the scar tissue usually isn't that bad compared to someone that doesn't have a connective tissue disorder. So redos in the Marfan's population is actually a little bit easier. So that's one thing that people have to look forward to. It's not going to take as long. But I'd say total from start of operation to finish for a hemiarch procedure, usually about 4.5 to 5 hours. For a total arch, I'd say probably 6 to 8.
Yeah, that's a long time. Yeah, I was going to say it's more than just you sewing. Right?
Yeah, yeah, absolutely. It's that's the fun stuff. But it's what's fun about it is each step of the way, as you introduce perfusion, you're assessing, all right, is the heart taken care of? Is the brain taken care of? And distally, how's the kidneys doing? How's the liver doing? And, it's balancing all of those. And also it's with the conduction of the operation. If you just focus, all right, we're going to do the arch vessels now, and then we'll address distally and then proximally, you're going to be there a whole lot longer. And so it's a dance. You can do a little bit here and then go back down here and then go up there based on where you are in your temperature management. So there's a lot of temperature management that goes into it, as we talked about. And so you conduct the operation based on temperature. So that allows you to go around.
And so, and just going back to that brain perfusion, right near the end of your talk, you said that mortality was lower if that was done, but you didn't give any numbers. People are asking about mortality rates. So,
Yeah,
go over that again.
Yeah, so I think it's a little bit hard to give a general, but and I knew people would want to be pinned down with a general number.
A range.
A range. So if you're looking at elective arch replacement, mortality on that, nationally is going to be somewhere on the order of, 2 to 6% for elective. But if you're talking about emergency surgery, you're looking 10 to 15, 20%. Now, obviously, if you now separate that out into who used brain perfusion instead of just hypothermia, the numbers with hypothermia are worse. When you do hypothermia and cerebral perfusion, it's less. So we've got to get surgeons to start doing more cerebral protection.
And that kind of leads into something else that you touched on a little bit. If people can't go to Hoag, I mean, how do people find an experienced surgeon? What should they ask? Like, they don't know where to go. They need to at least know the questions so they can find the right surgeon. Yeah,
I think that's where the Marfan Foundation has done an incredible job of helping direct, and also the a lot of the patients are socially connected, so they can find that out from friends. But I think questions that you should ask your surgeon is, how many procedures do you do in the surgery that you need done? And, you can ask patients what their, outcomes are. I think that's a very fair question. And I'd be careful of the surgeon that doesn't want to answer that question.
That's a great point.
But I got to say, from a community standpoint, as far as the aortic community, on the surgical side, there's a real push for regionalization of these problems. And I got to say, in Orange County, it's already kind of happened. And, as your aortic program builds, people get the word out. And then, even if someone shows up at another institution with a problem, these aren't problems a lot of surgeons want to deal with. So the ER gets on the phone and they're dialing for doctors. And so that's why, having a center where his phone lines are always open is critical.
Great, thank you. All right, so we're going to go to Jill, who asked her question before we started the presentation tonight. She says her native arch is still intact, but she has Dacron everywhere else. Is the arch surgery more difficult when the ascending and descending aorta have already been done?
I wouldn't say it's more difficult. I think what would add a little difficulty is that you're now doing redo surgery from the front. But once again, the Marfan's scar tissue is less, so that's a good thing. And you now have landing zones for your graft. So we're going to try and I obviously don't know Jill's anatomy, but what we would say is we're going to try and land the Dacron graft and suture it to the descending graft so that we eliminate all the tissue. And, just because that's the one area of native tissue you have left, you may not never need a surgery if there's no enlargement there. And some of the talk among the aortic surgeons is changes in blood flow. When we put a Dacron graft in the ascending aorta, it kind of goes back to that original slide where the aorta expands and it contracts. So it goes back to the egg game. Well, if we replace that proximal aorta with a graft, that graft doesn't expand or contract. So now you're sending that impact zone distally. So it's resonating. And a lot of our proximal aortic patients describe this. And I'm sure people out there will notice that after their surgeries, they went home and then they were sleeping at night and they're like, oh, I hear my heartbeat. Well, it's because that Dacron graft, I always tell them it's like a bass drum. The heart, the blood hits it, and it resonates and it goes up to the native aorta, and the carotids go up in the bone. And in the bone, that's where your ears, the ear membrane, the tympanic membrane is. And that's how sound's generated. So your brain registers your heart sounds. So that is, it's a sound of a good heart.
That's a lot of anatomy today. We're getting vocal cords and ears. And
Yeah.
just about the vocal cords. We can go back to that for a second. Does it go back?
So some patients, it's a partial injury, meaning it comes back on its own. So sometimes we watch it depending on, when the ear, nose, and throat doctors look in there and they see movement, that's something we'd probably watch. If we're not seeing movement, then it doesn't mean that it's gone forever. It means it could just be stunned. And so what the ear, nose, and throat doctors can do is they borrowed a little bit from the plastic surgeons. So they can actually inject filler into the vocal cord and beef it up so that where it's separated by injecting it, they beef it up so it can meet midline. So then people get their voice back and their airways protected so they can start eating. Some patients need repeat procedures until it comes back. Other patients, especially in patients where it's an acute dissection and that dissection occurred in the arch, and that area is like a grenade went off. Those patients may have a permanent injury. So everyone's different.
I've spoken with people who've had aortic surgery and they have that voice issue. I never knew what it was connected to there. That
It all
was
goes
great.
back to anatomy.
Now I know. So if we can talk about Loeys Dietz for a second. You mentioned that patients having elective root replacement surgery, you generally recommend a total reimplantation of the arch at the same time, including an elephant trunk, or you would think about it? I don't know, we're hesitant about recommendations here.
Yeah, I think from Dr. Cameron's paper, just May of 2020, he raises the question that maybe we should be doing total arches in the Loeys Dietz patients that had elective root surgery, and that he kind of threw that out there for surgeons to discuss. And there's a lot of rebuttal. Dr. Cameron's one of the smartest guys I know. So if he's telling us to think about it, I think we should. Now, once again, the Loeys Dietz patients are presenting at earlier ages. And so that creates some other technical challenges as far as the grafts and stuff like that. So once again, it's going to be an individual recommendation.
Okay, great. Okay. This surgery, the aortic arch surgery, is this always done in an open way? Is there any way to avoid open surgery?
Yeah, well, for in our non-connective tissue disorder patients, we can, and it's called a debranching procedure. So that's where instead of connecting everything through the graft, we would actually separate those head vessels, those three, disconnect them, and connect them to a graft, and then put that on the ascending aorta. And then in the arch, we could deploy a stent graft to cover that area. So it's what we call a hybrid arch. There is technology coming out where we have fenestrated stent grafts where we can, the zone 2 arch is coming out. So it's essentially a branch graft device to fit in the left subclavian, or even take it into a zone 1 repair where it goes into the left carotid. So that stent graft technology is out there, but once again, not ready for prime time in the connective tissue disorder patients.
I think that's the key point.
Yeah.
There. Yeah, everybody wants that, but
of course everybody wants that, but the problem is that the problem was within the wall of the aorta, and so by putting the stent graft in there, it may destabilize things.
I think that's important to know, like why not,
Yeah.
So
yeah.
So
and it goes back to the stent graft technology. It's using radial forces to put pressure on that wall. Well, that's the whole objective of blood pressure control. We're trying to minimize the shear stress on the aortic wall.
Right. That's where all the weakness is. That's the connective tissue. So what likelihood is there for scar tissue to develop after a full arch replacement, and how would scar tissue impact the patient?
So yes, scar tissue is going to happen. Anytime we do surgery, scar tissue will occur. where the good thing about connective tissue disorder patients, their scar tissue is less, so that's good. So if another reoperation would be necessary, it's not going to be as bad as the non-connective tissue disorder patient. I think, there's not a lot of scar tissue problems that can occur. One thing that can occur after surgery is the pericardium around the heart can be inflamed, and that can actually stick to the heart. It's called constrictive pericarditis. I got to say, I've never seen constrictive pericarditis in one of our connective tissue disorder patients, and I think it goes back to the underlying components.
Okay. Can you talk a little bit more about the aortic size, which you mentioned before, and you said it's different number based on if the person's bigger or smaller. So if you're saying 55 centimeters, how does that compare for the larger person or for the smaller person? What are you looking for?
Yeah, so what we're looking for is essentially the size of the aorta in the segment we're interested in, but also what's it doing over time on serial follow-up? Is it stable or is it growing? Is it ever going to regress? Not unless we cut it out and put a graft in. There is different ways to measure that are critical, and we see a lot of patients at our institution for second opinions, and they've been told somewhere else that they need surgery, and then they come in and see us, and the measurements were wrong. So it's really important to measure appropriately and do orthogonal measurements, so you're really getting the diameter of that area. When it comes to the body size, not so much the arch, but in the ascending aorta, there's a lot of controversy with this. If you're I always say our 5 foot tall, 90-pound nurse, her aorta should be significantly smaller than mine, and mine should be significantly smaller than the 6'5", 280-pound tight end for the Chargers. And so it's got to be ratioed, and there's certain tools we use to determine that, and that's the aortic ratio and the aortic size index. So we're looking at patients' height, weight, and then their aortic size in the different segments. There's a big Yale aortic nomogram that actually, gives some comparison out of Dr. Eleftheriadi's lab in Yale that kind of helps guide surgeons as to where people fit into either low, moderate, or high risk for aortic emergency.
I know with children, we talk about Z-score, which is.
Yeah, Z-score is used specifically for the aortic root, and that's critical and gets used for adults as well.
Right, and that's the differentiation from normal.
Yeah, differentiation for normal. There's kind of a range for normal, and then we're taking into account the patient's height, the weight, and even their gender to come up with those scores.
When you replace the aorta, this is a great question. I never saw this one before. When you replace the aorta with the Dacron, what's the diameter of that tube, or is it based on the person?
Yeah, so we choose it based on the anatomy that we're replacing. Obviously, when you're trying to sew one circle to the other circle, it's easier to sew it if it's the same size. But sometimes based on the curvature of the arch, you may choose one area based on the size, but then when you bring it down, it's a whole different geometric form. And so, we're pretty good at sewing things together and looking at size differential, maybe a 3-to-1 ratio. If it gets too big, then that's where we'd say, all right, we're going to choose a separate graft and connect them. So there's a variety of graft sizes that we keep in our operating rooms. We choose it based on the location we're treating.
That's great. All right. You already answered so many of these questions that were submitted in advance. An amazing job. And there's some other people asking questions very personal to their situation. So probably not the best venue for that here. But why don't you hold on, and we're going to do some closing slides, and then we'll ask you for some final comments. Okay?
Sure.
So let me share my screen again, everybody. And just remind you that if your questions were not answered tonight, please submit them to Jan, the Nurse in our Help Center, at marfan.org/ask, and she will get back to you. As Michael mentioned earlier, we still have lots of programming coming up. Next week, we have Dr. Jay Shah from the Mayo Clinic in Arizona talking about adult cardiology issues. We've talked about surgery this entire month, and so now we're going back to some of the basic issues on cardiology before or after your surgery. And then in March, we have Personal Perspectives panel, and this is dads with Marfan, low seats, beds, and their input. We talk a lot, we hear a lot from Marfan moms or moms of kids with beds or low seats, but you know, dads have opinions as well. And it's important to hear their insights so that anybody who knows them, loves them, and wants to know how they're thinking about this, it's a big impact. And we have Mitchell Pariani, the genetic counselor from Stanford. He's going to be in there helping out with that as well. And something that we announced just today, new on our website, new announcement is our new kids club is starting March 18th. It's the first night of it. This is by request of parents all over the place who wanted a safe place for their kids who are age 9 to 12 to get together. And we have our social worker, Andrea, leading that. It's not counseling or therapy. It's a fun place, fun, safe place for your kids to get together. So I'll put the link to register in the follow-up email I send you guys tomorrow. We are on top of COVID, of course. Lots of questions since this whole thing started. We have webinars on our website. The recordings are there. Statements from our professional advisory board. Most recent one is about vaccines. We have a weekly COVID support group Monday nights. And of course, we have masks available through our swag store. So I'll send you that link tomorrow. Maybe Helene put that in the chat tonight, but wear your mask. And then other opportunities coming up soon. As Michael mentioned, our virtual annual conference is July 8th to 11th. We are going to be doing so much more than medical presentations. Great opportunities for you guys to connect with each other and with some of our amazing doctors. We have other virtual support groups. We have our Walk for Victory season kicking off next weekend virtually. Hopefully we'll get to do some in person this spring, but definitely virtual to start. And obviously lots of places for you all to connect with us on social media. Almost finally, I think we have Marfan Awareness Month. We are almost done with Marfan Awareness Month. I hope that you guys have seen a lot online and have enjoyed some of the programming that we've offered. We have our new t-shirts celebrating our 40th anniversary. We have our Day of Giving this week, and that's a way for you to help us make sure that we can continue doing education and awareness opportunities to help you all. And then to stay connected to us and get on our text list, and you can text Marfan to this number or LDS or VEDS, whichever community that you identify with, and we'll make sure that you are one of the first to learn about new opportunities that we have. And so with that, I just want to first ask Dr. Caffarelli if he has some final words and thoughts for our community here tonight. We had almost 100 people on, and so it's a great turnout.
Absolutely. Thank you very much for having me. It was a pleasure. I always love teaching patient stuff. So I'm really looking forward to seeing everyone in person in Newport Beach in 2022.
We look forward to being there. Michael, any final words?
First of all, thank you, Tony. Terrific, absolutely terrific, as expected. So we deeply appreciate your involvement. Also, I was just reflecting quickly back on, I think it was Jess Winder from London that was saying she would miss, or he would miss, the programming because, this was the final in a series. That got me thinking just briefly about the annual conference, because we're also hoping July 8th through 11 we'll have international opportunities for viewing that as well. So if you've never been to a Marfan annual conference, it won't be like the in-person one would normally be, or will be next year at Hoag, but it would be terrific to attend. So keep that in mind as well as that gets announced. So thank you. Have a wonderful evening.
All right. Thank you, everybody. Thank you, Helene. Thanks. I always appreciate your help. And thanks to everybody for joining tonight. Thank you, Tony. We really learned a lot tonight from you. So thanks so much.
You're very welcome. Have a
Good
great
night,
evening.
everybody.
Bye-bye.
Bye-bye, everybody.